an AARP Ohio volunteer, and it's my pleasure to welcome you to our monthly Wellness Wednesday program. Our medical expert for this evening is Dr. Benjamin Walter from Cleveland Clinic Center for Neuro Restoration. Dr. Walter holds an undergraduate degree in biology from Emory University and attended medical school at MCP Hahnemann University School of Medicine in Philadelphia. From 2000 to 2004, he completed his internal medicine internship, neurology residency, and movement disorders fellowship at Emory University School of Medicine in Atlanta. He received his MBA from Case Western Reserve University. His certifications are in psychiatry and neurology and specializes in medical and surgical treatment of movement disorders, including Parkinson's disease, dystonia, and essential tremor. He also specializes in intraoperative physiologic mapping for deep brain stimulation, DBS, and pre- and post-operative care of patients undergoing DBS research interests. His interests involve fMRI and dystonia and other movement disorders. Thank you so much for joining us this evening, Dr. Walter.
Thank you, Linda. It's a real pleasure to be here.
Thank you. And I believe to start us off, you have a PowerPoint presentation you'd like to share.
That's right. So welcome, everybody. And I'm going to talk to you about taking control of Parkinson's disease and really looking at this as a roadmap for you and your loved one. And if we can just go to the next slide. What's most important with Parkinson's is learning how to take control, and taking control of this disease comes with understanding and education. On the next slide, you'll see what is Parkinson's disease, and this is from the pathology of the brain, and what's circled there is what we call Lewy body. Now, Lewy body is a separate condition, but it's also the pathology that we see in the brain with Parkinson's disease. What happens is there's a protein called alpha-synuclein that builds up, and as it builds up, it causes damage to specific brain cells that make something called dopamine, which is a chemical for the brain. And that causes some of the changes that we see in Parkinson's disease. If you look at the next slide, looking at the anatomy of the brain, this is a schematic diagram of the brain, and you can see in cross section, so it's cut this way, and then the brainstem below. The area, the lower arrow there, actually shows an area called substantia nigra, and this is simply means black substance, but what it is an area of the brain that's pigmented and it's got melanin in it, and there's dopamine cells that come from this area. They reach up to that other area where you see the other area higher up called the basal ganglia and striatum. And what happens here is the dopamine allows the brain to work normally as long as there's sufficient supply. But in Parkinson's disease, you'll see that there's a loss of dopamine. And if you click one more time there, you'll see that there's a change in how that part of the brain functions. And you see there that without the dopamine, if you click one more time, that area becomes dysfunctional. And that really is the key change that occurs in Parkinson's disease. On the next slide, one of the keys to taking control of Parkinson's disease is really taking control of time. So with Parkinson's disease, you want to ask yourself, how much of your day do you spend on? When are medications working? When are they not working? How much of your day is spent in the off state where the meds aren't working, where you may have more symptoms, more tremor, more difficulty walking? Are you consistent with your medication timing? There's things that you can do, like using a medication timer, a watch, or cell phone to remind you when medications are due. And the timing is really important, particularly when we talk about the different therapies and all the different ways that we have to take control of Parkinson's disease. On the next slide, this shows you kind of an illustration of what happens over time. And so if you look at from the bottom of the screen there, it's time in hours, so 2 hours, 4 hours, 6 hours after the main medication that most people with Parkinson's take called levodopa is given, which is converted into dopamine. And that the white area illustrates as the blood levels go up to that dotted line, you get to a threshold where you get some benefit, and that benefit goes up and then it comes down over time in about 6 hours. So each pill lasts about 6 hours. What a lot of people don't realize is what the medication is actually doing in the bloodstream is shown with this red line is actually very quick. It's more like a 90-minute duration of benefit. And the reason there's such a difference between the two is that the brain actually recycles the medication and recycles dopamine and is able to reuse it over time. But as you can see when we click one more time here just to see what happens in moderate stage Parkinson's disease, and then again in advanced stage Parkinson's disease, uh, these curves start to converge together where the response you get from the medication is very similar to what it's doing in the bloodstream. This is simply because the brain isn't able to recycle the medication, but what's important is it still works very well. And so we have a lot of strategies to extend this good benefit over time using different formulations of medications and different types of medications to make it last longer and different therapies as well. Another big part of taking control of Parkinson's disease is realizing it's not just what you see on the surface. And this is a picture of an iceberg kind of illustrates that, where the iceberg is analogous to the motor symptoms of Parkinson's disease, the tremor, the stiffness, the difficulty walking, the things that people may think about when they think of Parkinson's disease. But actually, when we're caring for people with Parkinson's disease, we have to think about all these things. And there's a lot that lurks under the surface that's critically important and maybe even more important than just the motor symptoms as well. So that we call these non-motor symptoms, depression, anxiety, change in sleep happens in about 90% of people with Parkinson's disease. Loss of smell is often an early symptom of Parkinson's disease, and fatigue and apathy are other symptoms as well. So we have to deal with all these things, and they are different in different people, and everybody has a different lifestyle. So it's really important for the physicians and care partners to understand all these different aspects of what may be affecting our friends with Parkinson's disease. If you go to the next slide, this video is going to play, was shared by one of our patients who has undergone deep brain stimulation. I want you to take a look at this and see the power of some of the therapies that we have for advanced Parkinson's disease. So that's with the stimulator on. He's about to turn it off right there. And that little device in his hand is a remote that the patients actually have to take control of their own device and their symptoms. And so this kind of illustrates in the same schematic how deep brain stimulation works. So again, when dopamine is low, that network in the brain isn't working normally, and the rest of the brain doesn't work normally as well. And if we click one more time, we'll see a pacemaker wire is placed into structures in the brain, in this case in the subthalamic nucleus, which is that little yellow area. And it just paces the brain to disrupt that disruption, essentially, which allows the rest of the brain to work normally or more normally again. If we go to the next slide, we have other new advanced therapies. Many people saw a video of this patient on TV who had MRI guided focus ultrasound at the Cleveland Clinic. And this is another very new advanced therapy which uses MRI. It's a less invasive treatment in that there's no surgery involved, there's no incision. But in the MRI scanner, ultrasound is used to make a tiny little lesion in the brain where the ultrasound elements are all focused into one spot, and we're able to essentially make that lesion to just disrupt the tremor and create a lesion that permanently changes that, so that the patient has less tremor in their arm going forward. And this is again without any surgery or incision at all. Go to the next slide. In all of these therapies, we need to think about what our goals are, and how one person lives their life with Parkinson's is going to be very different from another. How the symptoms affect you are different as well. And so we're always focused and tuned into what are the main problems, the main challenges that a patient may be having. Are they having trouble just doing simple things like eating and drinking, writing, or crafts, or is it their job? Is it being able to move fast enough so they can get their work done or get ready in the morning? There's all different kinds of things and different ways that people are affected with Parkinson's disease. So we really want to understand what patients' goals are, so we can make sure that we have the right therapy that can do just that. If you go to the next slide. And so taking control of your health with Parkinson's is really important. And there's a lot of different ways to do this beyond medications as well. Exercise, turns out, is one of the most important things that you can do to take control of Parkinson's disease. And if you go to the next slide, I'll just highlight this event that we've had on an annual basis and is coming up on October 23rd, called Empower You, which is a day-long interactive symposium focused on health and wellness for people with Parkinson's disease. And it's not just for people with Parkinson's disease, it's also for care partners with Parkinson's and caring for family members and friends. So there's a web link there where you can sign up. The registration's open now, and this is available across the country. And what's nice about it is that the information there will also be preserved for some period of time. So be able to check in and look at it again over and over again over time if there's parts that you have missed. So I'm really interested to hear what your questions are. So I'll let us get to the next part of this program and hear some of the questions that you have for me.
Inspiring and brings us hope for the patient. What a wonderful, thank you for sharing that. Many of us were introduced to Parkinson's. I never thought much about it until Michael J. Fox many years ago was diagnosed. And since then, of course, he was very young at the time. And of course, Alan Alda was recently diagnosed. And the iconic singer Linda Ronstadt also was diagnosed. Can you talk about, first of all, is there an age range for Parkinson's?
Well, there's a range and there's an average, like anything, but it goes from very young to very old. The average age of onset of Parkinson's disease is typically 62. So it tends to be older folks. However, young onset Parkinson's occurs in folks under the age of 40. And then there's juvenile onset Parkinson's, which is in the 20s or less. So it's really a broad range. And because it's not really a life-limiting disease, people will live the rest of their lifetime with Parkinson's disease. And so the range of people who live with Parkinson's is even broader.
Are there, doctor, stages of Parkinson's disease? And if so, what can be expected in them?
There are different stages. The way that Parkinson's is staged is called the Hone and Yar staging. It's fairly rudimentary and really is used more for clinical trials. Of stage 1 involves one side of the body. It's really a bilateral disorder, so very few people stay in stage 1 for very long once we can detect symptoms on the other side, but it tends to be very asymmetric in that sense. Stage 2 is bilateral. Stage 3, there may be some balance problems. Stage 4, the balance problems may be a little bit more significant, where the patient or person requires some kind of walking aid or assistance, like a walker or a cane. And stage 5 is where the patient's in a wheelchair and not able to walk. Very few people actually are in stage 5. Very few people are in stage 1. Most people are in stage 2 and 3 for most of the time.
And is there a certain time period for each of these stages, or it depends on the person, would you say?
It depends on the person. Usually stage 3 and above usually occurs after 4 or 5 years or more. So the early stages before that. And I would say, maybe a more useful way of looking at Parkinson's and the progression of symptoms is that there's the premotor phase, which is really before you're actually diagnosed. Parkinson's has been going on for a very long period of time, actually, usually 10 years or so before diagnosis. And that's because there aren't any motor symptoms. It may just be constipation and loss of smell, a change in sleep. Some patients have REM sleep behavior disorder where they talk in their sleep or they act out their dreams. So all that can occur years before diagnosis. And just because you have some of those changes don't mean that you will have Parkinson's disease either. Once you have symptoms in the symptomatic phase of Parkinson's disease, then we start patients eventually on medications, and there's a period which was commonly referred to as the honeymoon period, which is after starting medications, the symptoms are usually fairly dramatically reduced in most cases, but not every. And in that case, it almost feels like you don't have Parkinson's disease, and people can stay like this for a very long period of time. If you think about the slides that I showed earlier, that mild stage where the medications are lasting from dose to dose really represents that period. Things get a little bit more complicated later on when patients may develop motor complications. And this is just that the medications are not lasting from dose to dose. And really, we have a bunch of new medications and strategies and deep brain stimulation, focused ultrasound, and other therapies that work very well in this stage to help control the symptoms regularly throughout the day. And then more advanced stages, there may be some complications, the walking difficulties or memory problems and other things that may occur then or other times, either unrelated to Parkinson's disease in later stages as people are older as well.
You mentioned some early signs could be, visual dreams, constipation. Is there a time when you really should think maybe this is Parkinson's as opposed to just a phase you're going through if there's no, physical signs?
Sure. Well, I think what really clues people into Parkinson's, though, is some of the physical signs, but it progresses very slowly, and so it may be subtle at first. But a change in dexterity, difficulty walking, slowing down, a loss of expression in the face, and maybe even a little bit of tremor that occurs at rest. But you don't have to have tremor. But somebody that's experiencing some of these things and they are sort of progressing, if looking back, they also know that they are experiencing constipation, they've had some loss of smell, there's been a change in their sleep where they have these active dreams where they're talking in their sleep or acting out their dreams. These would all be clues as well that may suggest that Parkinson's is a possibility.
Okay. And is Parkinson's genetic?
It can be, but Parkinson's usually is not genetic, in that about 10% of people with Parkinson's disease may have a gene that's inherited in what we call a Mendelian fashion, where it's passed from generation to generation, and a high number of offspring may have that gene. It also doesn't mean that they'll actually have Parkinson's either. So that's about 10% of cases where that is the case. Usually these are young onset cases, and the other clue would be that there's already multiple family members, direct family members, not distant cousins, but somebody who is a mother, father, sister, brother, or child with Parkinson's disease. If you have multiple family members in those categories, that would be a clue that there may be a gene involved in that family that could be determined with genetic testing. Otherwise, genetic testing doesn't really tell us whether somebody has Parkinson's or not. It just tells us a little bit about why they have it and can help inform whether other family members may be at risk.
Very complex issue currently. Clearly it is. Nadine on Facebook asks, is it true that non-tremor Parkinson's advances faster than tremor Parkinson's?
That's a very good question. Everybody is different. So I guess the first thing I would caution is that the most predictive pattern for how somebody's Parkinson's is going to progress is how it has been progressing. And so if somebody has Parkinson's and it's progressing slowly, that's unique to them, and that's probably how it's going to continue. People who have more asymmetric disease, so it's more on one side of the body than the other, or have tremor, often do have a slower progression than those who do not have tremor or have more very similar bilateral symmetric disease. But again, everybody's different, and there are people who don't have tremor who also have a very slow progression as well.
Okay. Nancy on Facebook asks, can a SPECT, S-P-E-C-T scan diagnose Parkinson's, as does the Cleveland Clinic utilize it? So, doctor, could you explain what a SPECT scan is and if that's a possibility?
Sure. Well, for the most part, there isn't really a test that's diagnostic for Parkinson's, in that most cases Parkinson's is made as a clinical diagnosis where you see an expert neurologist or movement disorder specialist who's able to put the history together and the signs and symptoms and make a definitive diagnosis. However, there are some tests that can be very helpful in supporting that diagnosis, particularly when we have a high suspicion and we need some additional information to support that. And a SPECT scan, something called a DAT scan, which is a dopamine transporter scan, is a nuclear medicine scan that is able to light up the part of the brain in the basal ganglia, actually, where those dopamine cells project to, as you saw in my diagram. And if those dopamine cells have been lost to a substantial degree, it won't light up as much, and the pattern that we see of the uptake of that radionuclide tag will show a different pattern and can be diagnostic of Parkinson's disease. It's best used in cases where there is high suspicion, but some uncertainty. In most cases, we don't need to use that, and the clinical diagnosis is actually better.
Lori on YouTube asks, what are the most promising and currently available therapies or medications for the treatment of Parkinson's?
That's a loaded question and a good one. I think, the most promising therapies, for any individual is going to be different. I would say the most potent therapy is still levodopa, something that was discovered in the late 1960s and was FDA approved in 1971, is still one of the best that we have, and that is a precursor to dopamine. The brain and the body take that and turn it directly into dopamine in our brain cells, so it works the way that dopamine should work. But as I pointed out, there's a lot of limitations to that. So for people who have their medications wearing off, we have longer acting forms. There's an extended release form called Ritari. There's dopamine agonists. There's patches that are 24-hour preparations. All these different options have some limitations, though. There's something called Duopa, which is a way of giving levodopa continuously through the stomach, through a pump, essentially. And then the deep brain stimulation and focused ultrasound are very potent therapies to give patients 24/7 control of their symptoms. But not all of these are best for any individual. And in the future, I think there's a lot that's being researched, and there's a lot of therapies that may also be disease modifying, or things that may actually change the course of Parkinson's disease. And that's really where things are going. But we're not quite there yet. There's a lot of what we have in clinical trials right now is starting to go in that direction, where we might have something that slows the disease down. Right now, the best thing to do that is exercise, something that everybody can do on their own and start today.
And actually, to follow up to that, Cindy asks, how far along are researchers in looking for a genetic marker for Parkinson's?
Yeah, so again, what's interesting about Parkinson's disease, it's not really one disease. It's really a syndrome or a collection of diseases that can have different genetic causes, or not even caused by a particular gene. As we've learned about the different genes that are involved, they have some things in common. A lot of them have to do with some of the same kind of machinery in the body as far as our cells and how they work. So it gives us some clues. But there's a number of different ways that things break down that cause Parkinson's. If you think of an analogy, having Parkinson's is like having a car that won't move. And just because the car doesn't move, there could be a lot of different reasons. The engine could be broken. It could be the transmission. You could have flat tires. There's a lot of different things that can cause that. And so when you look from far away, all you see is a car that can't move. And that's really how we diagnose Parkinson's. It might not have any gas. What we need to do is understand the differences and see, over time there might be some very specific treatments for different genotypes of Parkinson's disease.
Is the phrase Parkinson's disease, is that sort of like saying Alzheimer's, a catch-all phrase for dementia? Are there different kinds of, Parkinson's-like diseases? Is that sort of a comparison in a way of an umbrella phrase, and there's different ones?
Kind of, not, but not quite. So,
Okay.
I mean, dementia refers to the symptom of having memory loss that is significant, and Alzheimer's is one of the causes of that. I would say, though, that Alzheimer's and Parkinson's are very similar in the sense that they're both syndromes of a particular neurodegenerative type of condition. They both actually have multiple different genetic potential causes and other causes, and they all look very similar, but there are differences. So it's still, again, looking at things from far away, something that has a lot in common, but when you look at a higher level of detail, there are a lot of different variants. For Parkinson's disease, there's Parkinsonian syndromes, and then there's idiopathic Parkinson's disease. The different atypical syndromes are very different and have different pathology even. And then even if it's the typical form of Parkinson's disease, there's a lot of different subtypes and presentations. As we talked about people who have tremor and people who don't have tremor, they both have Parkinson's disease, but they're very different.
And actually, Cindy on YouTube as a follow-up says, what is the difference between Parkinson's and Parkinsonism?
Yeah, very, very good question. Some of this is a semantic issue, and it depends on how it's being used. But Parkinsonism refers to something that is Parkinsonian or Parkinson's-like. So somebody might use that term in a more vague sense without being specific of whether it's Parkinson's disease or an atypical form that is similar to Parkinson's disease. But typically, Parkinsonism is usually being used more to denote an atypical form, or atypical Parkinsonism would be the full terminology. And then there's multiple different diseases that are very different within that. There's something called progressive supranuclear palsy, multiple systems atrophy, diffuse Lewy body disease. These are all forms of atypical Parkinsonism, which are completely different from Parkinson's disease itself, but still have the slowness, the stiffness, the difficulty walking, and sometimes with tremor, as we see in Parkinson's disease.
Patty on Facebook asks, my mom has essential tremors. Does that mean she will ultimately get Parkinson's disease?
Another very good question. Probably not. Parkinson's disease and essential tremor are very different conditions. Essential tremor is a different kind of tremor, where Parkinson's, the tremor is at rest when you're just sitting there not doing anything, and you go to move and the tremor goes away. Essential tremor is a condition where you don't have any tremor at rest typically, and when you go to reach for something, your hand will shake. Holding a cup, it'll shake, and it gets worse as you go towards something or bring it towards your lip. It'll shake. It causes great difficulty with writing, because just as you go to write, your hand becomes shaky. Different condition altogether, but there is just a little bit of overlap where some people with essential tremor, more often than chance, may develop Parkinson's at some point. And there's a little bit of overlap there, but I would say for the majority of patients, the vast majority of patients, completely different conditions and doesn't really put you at very high risk for developing Parkinson's.
Well, Doug on Facebook notes, which is true, our conversation tonight seems to focus on therapies, but he'd like to know, how are we doing in the search for a cure?
That's a very good question. And I guess I always like to frame that question in that, we have to think about what we mean by a cure for Parkinson's disease. Because it is a degenerative condition where there are a buildup of changes in the brain where there's a loss of function. And that pathology is progressing and that's causing that damage. The most important thing, and the part that we don't have yet, but again, there are research studies ongoing right now looking at this, is a treatment that definitively slows the progression of that pathological change and slows it down to a stop. We would call that something that is disease modifying or neuroprotective. And again, there are things that are research studies that are looking at just that. We don't have that answer yet. There are different types of actually some chemotherapies that have some promise that are being looked at. There are some antibodies against alpha-synuclein. This has been done with Alzheimer's, very hot in the press and controversial at the same time, because I think the more we understand it, just getting your immune system to remove some of the pathology may not be the answer, but that's one approach. And a number of other different drugs that may affect the clearance of alpha-synuclein, that protein that builds up, and those might be neuroprotective or disease modifying. When we have something that slows it down significantly enough, then if we caught somebody and diagnosed them early enough, then you would expect that and treated them, that their disease would not progress to the point where they had symptoms, and that would effectively be a cure for that individual. And I think the other type of cure that is on the horizon is when we have very effective treatments, which we do, in combination with something that would slow the disease down. At any stage, we might get to the point where we can deliver therapy to somebody, and they no longer need to think about suffering from symptoms of Parkinson's throughout their life. And that's really, functionally what the cure is. But there's still changes in the brain that are there, and taking that back, I think, would be much more difficult to do. But restoring function on a permanent basis, I think, should be the goal to any major therapy in Parkinson's disease.
That video that you showed earlier with that wonderful patient, is that kind of in the early stages, or would more people be open to that kind of brain stimulation surgery?
Typically, deep brain stimulation is used for more advanced stages in most instances where the medications, while they work well, they've gotten to the point where they're not delivering consistent benefit over time. And this is something that works in the same circuit. The medication response is generally predictive of getting good benefit from deep brain stimulation, but now it's working all the time. So people that have had it for a little while, the only exception to that is typically when there's significant tremor that doesn't respond to the medication. A lot of times the tremor does, sometimes the tremor doesn't, and it turns out that both deep brain stimulation and focused ultrasound are very effective at controlling tremor at any stage and regardless of whether the medication affects it or not. Of course, if you think about it, it's not really reasonable to suggest deep brain stimulation for somebody if the medications do control the tremor very well, because then just taking a pill is going to be a lot easier with less risk. So we offer it to patients when they're really stuck and we have a promising opportunity to really control their symptoms with these therapies.
Nancy on Facebook asks, a psychopharmacologist friend suggested adding Wellbutrin to Levodopa to be more effective. Have you ever done this?
Okay, so I think they're talking about adding Wellbutrin to levodopa.
Levodopa, thank you. Levodopa.
That drug, or Sinemet, as it's often called, the brand name, that's converted into dopamine in the brain. Wellbutrin is an antidepressant, and it's an antidepressant that does increase dopamine a bit more than other antidepressants. So it's something that I think is always on the minds of people treating people with Parkinson's disease. Um, yes, it's more effective really as an antidepressant, and each antidepressant is different in how it works and which patients it's best for. But it does, affect dopamine to some degree. I think that the majority of the effects you're going to see with Wellbutrin, though, is really on depression and not on the motor symptoms of Parkinson's disease.
You mentioned that the mental toll it takes too. We have a question that was written in. What can I do to take the best care of myself emotionally and mentally so as to be able to take care of my partner? I already address our nutritional and physical needs with proper diet, making sure he gets enough exercise. So can you talk just a little bit about the whole mental health aspect, not only for the patient, but also the caregiver?
Absolutely, and that is something that is very important, and something we spend a lot of time focusing on as well. Is the health of the care partner, and also empowering the care partner as well to take control of Parkinson's disease. So just like we have Empower You, really focused on Parkinson's itself, which is really for everybody who's touched by the disease. We do have a care partner Empower You as well, that just focuses on things from their aspect, because I think it is different. Care partners really need to make sure they set time aside for themselves, that they're not consumed by caring for their loved one. They need to learn how to make sure that they're still treating their loved one as the person that they are and always were, and that they don't have always like a therapeutic relationship where they're more like a doctor-patient relationship. They are always caring for them and always translating information from the doctors and the providers. But it's really important that they're able to keep their relationship intact as well. We offer a lot of resources in understanding how social workers can help. We have psychologists who work with this program and help advise not just our patients but our care partners in their own mental health, making sure that care partners take a break for themselves, maybe getting some respite time, getting somebody in the house sometimes to help with their loved one so they can go out and do errands, or just have some time to themselves. It is very important. And a lot of people may have a tendency towards just focusing on all the things that need to be done and just constantly working to take care of their loved one. But it's important that to do that most optimally, they have to take care of themselves as well.
And of course, this is a subject that so many caregivers wrestle with. When do you know that it's time that basically you can no longer take care of that loved one? And with Parkinson's, how do you know that the time has come to get further help?
Sure. Well, when there's safety issues that can't be solved otherwise, I think when you're struggling, or there are safety issues as well, if it's overwhelming, the first thing to do is to reach out to your physician and see what other strategies there are, what resources there are. Working with a social worker can be very important to see what resources you can get into the home. And if there's things that can be done to make everything easier, that might be all you need. You might need somebody to come 3 times a week and help with bathing and showering, for example. Might be one thing. It really depends. But everybody's different, and it's a good conversation to have with the patient's doctor and see where things are, and what can be done to make things better, and potentially not need to move on to a different phase, with extended care facility or something like that.
A reader writes, boxing for Parkinson's disease was so important for my husband to stay strong. The pandemic shut that down, and he has lost weight and strength. What kind of exercises can you recommend to recover that strength?
Sure. So the boxing therapies for Parkinson's, which is not actually sparring or hitting each other.
What are they? What are boxing? What do you do with that?
So I mean, there's a number of different groups that have done this. Probably the best known is Rocksteady, which started it out of Indianapolis. And this is a targeted therapy, a targeted exercise program, a group exercise program for Parkinson's, that's around the theme of the kind of training and agility work that people do when they're training for boxing. So working with a heavy bag, a speed bag, maybe some footwork, lots of calisthenics and different types of exercises in a group with people with Parkinson's disease. So you get to take your frustration out on a bag, which is great. You get to do it with other people who are fighting the same battle, which is also great. What's really important though with that is that it's learning a skilled exercise. It's not an easy thing to do. I did it, I think about 10 years ago. Drove out to Indianapolis with a bunch of friends and colleagues and patients with Parkinson's disease, and we did 2 back-to-back classes, and I can tell you it was difficult. And I struggled to keep up with the patients with Parkinson's that have been
Is
doing.
it hard for someone with Parkinson's to learn this? Are they already having maybe some
Hard
cognitive
if you don't have Parkinson's, but if you put your mind to it, you can do anything. And when you're learning a skill like that, and you do it over time, you get good at it. And when you learn something like that, your brain is actually building connections in the brain. You're connecting neurons that are not well connected, they're not normally connected. And when neurons are strengthening like that, there's actually nerve growth factors that help do that. And nerve growth factors also help keep brain cells alive. And these brain cells are specifically those brain cells that are in the area involved in movement, which is affected by Parkinson's disease. So it's not really surprising that these types of skilled exercises would be very effective at helping improve symptoms of people with Parkinson's disease. And exercise may, to some degree, slow the progression of the symptoms down, maybe even the disease itself. And that is one of the mechanisms that people have discussed that may actually happen. So it's a great way to do that. There's lots of other skilled exercises that are very popular in Parkinson's, and they can be used as well. You've got the Lee Silverman Big and Loud programs, which focus again on skilled and big exercises, can be very effective. You've got Delay the Disease, which is a personal trainer-based program that's also very effective. There's a lot of different approaches that folks have taken, and probably the most important thing about exercise is to do it.
Yeah, for all of us, but especially for people who are struggling with that.
It doesn't work if you don't do it.
That's very true. A couple more questions along that mental health vein. How can I best respond to what seems like ever new challenges and disappointments in my wife's abilities? How do I respond to my wife's and my own feelings?
With challenges and disappointments, is that the question?
Yep.
Well, I think, as with anything, you need to keep a positive attitude, and positive thinking goes a long way. And if you have a positive attitude towards anything, even if some things can't be achieved, you're going to achieve a lot more than you could otherwise, and you will surprise yourself at what you can do.
Okay. We have Ellen on Facebook. How does one distinguish Parkinson's disease gait issues from normal pressure hydrocephalus gait issues when both conditions have been clinically confirmed?
That's a very good question. We see a lot of patients with both of those.
Can you explain what normal pressure hydrocephalus gait is?
Yes, so normal pressure hydrocephalus is a condition that occurs where the spinal fluid, which is the liquid that bathes the brain, basically cushions it on the outside and on the inside, which keeps our brain safe, and also provides a lot of other different aspects of supporting our brain health. It's not being reabsorbed the way it's supposed to be reabsorbed, and very slowly over time, what happens in these patients is that it builds up on the inside and pushes the brain out, and so it stretches the brain and pushes it towards basically the skull, and causes damage to some aspects of the brain. The main things that it affects are walking, memory and thinking, and bowel and bladder, or really bladder control mostly. So those 3 things are affected by NPH. We can see the difference fairly easily, although there are a lot of people that are borderline, where you might see some aspects of both. You can even develop a tremor or some Parkinsonian symptoms with NPH, which will really confuse things. But when there's any question, and we see somebody who has more of a wide-based gait instead of a narrow-based shuffling gait, we start to think about normal pressure hydrocephalus. The feet tend to stick to the floor, but you can get freezing with Parkinson's, which is very similar, but they're usually more narrow-based. We get an MRI or a CAT scan if it shows dilated ventricles that are out of proportion to any shrinkage of the brain that occurs with any neurodegenerative process. That's highly suggestive of normal pressure hydrocephalus. And then usually those patients undergo either a large volume spinal tap or a drain trial where we take off some of that spinal fluid pressure and see if temporarily if that relieves the symptoms. And if it does, then they might be a candidate for what's called a VP shunt, which is a more permanent way of treating normal pressure hydrocephalus. But walking problems can occur in Parkinson's as well, particularly gait freezing, where you try to take a step and your feet kind of stick to the floor. It's hard to initiate steps or on turns. But when we see that in the context of other symptoms of Parkinson's, the tremor, dexterity, slow dexterity in the hands or loss of animation in the face, then that's suggestive more of Parkinson's disease. And the other thing about Parkinson's that's very helpful in the diagnosis is it responds to the main medications for Parkinson's. So if we give somebody who looks like either one of these cases, levodopa, if they respond dramatically to it, that's a strong indication that we are dealing with Parkinson's disease and not normal pressure hydrocephalus.
Well, actually, I had a question. The listener wrote in, I very frequently have freezing episodes and it is difficult for me to walk. What advice do you have to improve this problem with the freezing episodes?
Yeah, freezing in Parkinson's is a very stubborn and difficult problem. Sometimes it responds to the dopaminergic medications like levodopa. So if that is the case, if we're noticing it more when the medications are wearing off, so between each dose at the end period of time just before the next dose is due, if that's when there's more freezing, then working with your doctor to find the right regimen to optimize your therapy to not wear off as much is one way to go. But you have to work closely with them because in some cases there are people that will actually have freezing that gets worse as we go to a higher dose at some point as well, or is in many cases resistant to the medication. And in those cases, it's really a matter of strategies working around it. Certain cues are very helpful. So if you step over something, it's a natural stepping reflex. So if you see something on the ground and you try to step over it, that's an easier thing to do than initiate a step. And once you do that, you can keep walking. And so a lot of people will use these tricks. They might throw a laser light across the floor in some cases, or somebody might put their foot out and say, please step over my foot. And then they can keep going. They can at least stop that freezing episode and continue along. So these kind of strategies are things that people learn as ways of controlling the burden of those symptoms, but it's different for different people.
Doctor, we have a question from YouTube. Are there currently any promising drug trials going on? And are you aware of any that are happening right now?
Yes, lots. We have about 20 different studies that are open right now at the Cleveland Clinic, and there's lots of different trials, really across the country.
Can you share the names of a couple if you feel comfortable with that?
Sure. Well, one I would say is that anybody can go to the Cleveland Clinic website and look to see what we have. If you go to clinicaltrials.gov, that's a website that is a national registry for all clinical trials. And every single clinical trial has to be listed there, so it'll be there. We have trials for a lot of different medications. There's a levodopa patch pump, which is a continuous form of levodopa that's not a surgical therapy, more like an insulin pump called Neuroderm that's enrolling right now. We've got a study on constipation, something called Enterin, that's enrolling right now. We've got the tempo studies. There's a dopamine agonist, a D1 dopamine agonist that is in that trial, and there's a bunch of different types there. There's the Spark study, which is another really interesting trial. It's a intervention against protein involved in LRRK2, which is one of the genes that is involved in a genetic form of Parkinson's disease. And so there's an intervention in spinal fluid with that. So there's a lot of different studies that are going on. And I would say clinicaltrials.gov or the Fox Trial Finder is another good place to find out about that. Or go to the Cleveland Clinic website, go to the website of a major institution in your neighborhood, and you'll find lots of different opportunities.
Okay. Very timely question. Could you discuss the COVID vaccines and Parkinson's? Nadine asks.
Sure. Well, first of all, COVID itself is, unfortunately has taken a huge toll on our population and our patients with Parkinson's disease. I've never had so many patients die in a year as I've seen with this pandemic. So many faces that I can still see and remember that suffered from COVID and died very quickly in the early phases, and still, as the pandemic continues. So it's certainly something to be taken very seriously. People with Parkinson's, when they get sick, a cold, a urinary tract infection, or upper respiratory infection, their symptoms are a lot worse, and it's a temporary thing. Once the infection is gone, they're back to normal again, typically, as long as there wasn't any permanent sequelae or damage from that infection. But because they're fragile like that and their symptoms get worse, they're really at risk for developing other complications like aspiration pneumonia and falls and other things that may happen if they do get sick. So, particularly in a respiratory virus like COVID, they're at high risk for complications of COVID. I don't think people with Parkinson's are at high risk for getting COVID, but more for the complications of it and dying from it or suffering from it.
And as far as getting the vaccine, if you have
with regards to the vaccine, it's the most effective way, in addition to masking, to prevent getting the coronavirus. And it is recommended for all patients with Parkinson's disease, both by us and by the Parkinson's Foundation and other organizations, unless there's some major health reason why they shouldn't. But on the basis of having Parkinson's, it's just even more reason to get vaccinated. I do think that, just like anybody else, a couple days after you get your vaccine, you may not feel perfectly well. Your Parkinson's symptoms might be a little bit worse. You might be a little bit shaky, just like having a cold would. But it's much better than having severe pneumonia and being in a neurocritical care unit. So I would recommend getting it. And I think, the other question that goes along with that is now the booster shots for those who have been vaccinated. And I think that is around the corner for all of us, and certainly would recommend it for our patients with Parkinson's as well.
we just have about 5 minutes left. So I want to ask a couple of things. Are there any tools or do you have any information on how to help with feeding oneself because of the shaking? This writer says it's very hard to cook and eat. Any advice for that person?
Yeah, certainly that can be a challenge with Parkinson's, particularly with tremor, and actually any movement disorder with tremor, including essential tremor. There's something called liftware, which some people find useful. It's a kind of fork or spoon that actually has a gyroscope in it, and it will adjust to your shaking, and so it kind of shakes in the opposite way and gives you a more steady utensil. Weighted silverware is a more simple way to do that as well. Sometimes cups with lids and things like that can be useful. Working with your neurologist to see what we can do to get control of your tremor again. Treatments like deep brain stimulation and focused ultrasound can dramatically reduce tremor. So if you're a candidate for that, that's the kind of task. If somebody's having trouble eating, something basic like that, if we've tried all our tricks with the medications, and somebody's a good candidate for procedure, that's a good opportunity to improve quality of life.
Does physical therapy help at all?
Absolutely. Physical therapy is just one of our strategies with exercise, and it's a good place to start. I recommend physical therapy, even at the beginning, after diagnosis is a great place to start. Understand what you can do and start learning some of the tricks of controlling symptoms with Parkinson's. What does an exercise regimen look like or should look like with Parkinson's, and what are some of the individual challenges that people have? It's good to learn that early on so you can incorporate that into your lifestyle.
Okay, and a couple personal related questions from readers. How can I better help my husband cope with his Parkinson's, depression, and overthinking? Helping him cope.
Uh, yeah, well, depression is very common with Parkinson's disease. Actually happens in about half of people with Parkinson's. We do believe that it is on a chemical basis. It's not just being frustrated and upset because you have Parkinson's disease, but actually the chemical changes in the brain. And we see it more in Parkinson's than for, say, something that's much more serious and deadly like ALS or Lou Gehrig's disease, which has a very short life expectancy. So more evidence that we need to really look at how to treat depression. People with Parkinson's may need antidepressants. There may be medications that can be adjusted to help control those symptoms. Sometimes just working with a psychologist. We have a psychologist as part of our team, Taylor Rush, and we feel that that's a very important part of the multidisciplinary approach to treating Parkinson's disease. It's very good to talk through things and see, and not just for the patient, but also for the care partner. Usually, when depression's involved, it permeates everything and can affect everybody around. So important to kind of understand where that's coming from and get control of it.
Another listener wrote in, how do I get my husband to share when he notices some change in his condition? It sounds like he's trying to hide some of those changes. And is there a way that kind of a communication for that she can use?
Well, that's a really good question. I think, a lot of people may be proud and try to be independent. And with Parkinson's, you don't really necessarily want to be dependent on others. But it's important, I think, for the patient to realize that their loved one is really in it for them and for the long haul. And working together, you can achieve a lot more than you can just working alone.
And two more questions. The first is, what are your suggestions for handling sundowning time?
So sundowning is referring to that situation that occurs in people who have Parkinson's or other degenerative conditions with dementia or some memory problems. And so at the end of the day, when there's typically more fatigue, memory function declines, and it may be confusion. There might be psychosis where you see things that are not there, delusions where you think things are going on that aren't going on. And so the strategy for that really is really multifaceted. As physicians, we work to adjust the medications to optimize them. A lot of people, even non-neurologists, may not know all the differences of the medications and how sensitive people with Parkinson's are to them. So we'll often look at the regimen and try to understand if there's even something like a bladder medication, for example, which is worsening memory function, could be adjusted to a different bladder medication so that memory and thinking is better. We might choose different flavors of Parkinson's medications for these folks that are less likely to cause confusion and delusions. And then there are medications that treat psychosis in Parkinson's, and it's really important to choose the right ones there too. A number of different antipsychotic or medications for psychosis actually make Parkinson's worse. And so there's only really three, pimavanserin, quetiapine or Seroquel, and clozapine or Clozaril, which are often safely used in people with Parkinson's disease. And most of the other ones will make Parkinson's worse. So it's really important to pick the right medications. And of course, only one of those, pimavanserin, is actually FDA approved for that purpose.
And finally, how can I encourage my husband to get out more, visit grandchildren and friends? His world is getting smaller.
Yeah, I think one way it probably depends on what his interests are and what makes him do things. But one thing I think that's really effective is getting involved in a Parkinson's exercise program. These programs are groups. Everybody's working together. Everybody's in the same boat. And even if you're not ambulatory, there's a role. There's a lot of chair exercises as well. So at all stages, whether you're really active and still running around and doing stuff, or less active, there's different levels of exercise programs for you. And so I would get involved in a Parkinson's exercise program and start there, because you're going to be slowing the disease down. You're going to be taking control. You're going to be have the benefit of the camaraderie and that social reinforcement and that support from that group. And there's nothing better than that.
Well, on that note, thank you so much, Doctor, for joining us tonight. You've given us some hope and also a very inspiring video. Thank you so much for that. Thank you for joining us tonight for Wellness Wednesday. We hope to see you next month, September 29th, when we'll be discussing back and neck pain. Thanks so much. Have a great month.
Thank you.